Okay, guys, I'm going to get started. So we had like an upper extremity block lecture, a lower extremity block lecture. This is truncal. So pretty much like below the clavicles to the inguinal region we'll cover. I'm not going to really talk about thoracic epidurals, lumbar epidurals, but obviously that is a good choice for any extensive bilateral injury. So let's get rolling. A little bit about what local to use. So basically, these are volume blocks. You know, they're little tiny nerves, and if you're just looking for analgesia, you could go with 1/4%. Certainly, when you go to bilateral blocks, you would use 1/4 because you can use twice as much. But in general, you know, everyone knows the rules of with 1/4%, as many kilos as they are is how many cc's you can use, because there's 2.5 milligrams per ml per quarter, and you can have 2.5 milligrams per kilo. And so with 0.5%, when you grab a bottle of half, it's half of that volume. So, you know, a 30 ml bottle is always going to be within the realm of safe for an adult, and you can push that to the 40 ml bottle of 0.5 if you needed some more space. But in general, when I can, I keep it to that 30 mark. And then with Exparel, and this will happen a lot where the surgeons may not be aware of what they can mix. So one little bottle of Exparel with 10 ml, it has 133 milligrams of bupivacaine in there. And you can use half of that with a bupivacaine. So you can use a 10 ml bottle of 0.5 and a 10 ml bottle of 0.25. That would be 75 milligrams. You can mix that with it, or you could use more if it's all 1/4. And obviously, when you use 2 bottles of Exparel or 120 ml bottle, you can use 206. That's 266 milligrams. So now we're talking about a lot of bupi, right? Like I was just telling you, you can use about 150 milligrams of bupi. We'll realize that in that 20 ml Exparel bottle is 266 milligrams of bupi, but it's released slowly over 96 hours. And so the plasma level doesn't take a huge spike. But you also could see the danger if you mixed it with, say, lidocaine, and which you cannot do, to be clear. If you put lidocaine and Exparel together, it released 266 milligrams of bupi plus whatever lidocaine you had in there. Now you're talking about a real situation. So always have your, you know, during the timeout, we talk about what locals in the field, you know, really perk up there and say, you know what, this is a 45 kilogram frail elderly lady and they're planning on using 0.5 bupi. Like, hey, in the field, just use 1/4. It's going to be safer because it's half the dose. You always want to use your lowest effective concentration, which is your lowest volume times your lowest product concentration. Quickly about planes, just because I'll be talking throughout the lecture and saying these terms, I want to make sure you understand that you have the mid-clavicular line, the anterior axillary line, and the mid-axillary line. Yeah. Yeah, so there's no question that if you use all Exparel, you're going to have very delayed onset of the block. In fact, I did adductor at the surgery center 2 days ago, and I put Exparel and bupivacaine, and I noticed that the onset's slower than just using bupivacaine alone. So you really do need to mix. And you can use half the number of milligrams of Exparel in the form of bupivacaine. And they kind of round up. So the 10 ml bottle is 133. They round that up to 150, and they say you can use 75 of bupi. One 10 ml bottle of 0.5 bupi is 50. One 10 ml bottle of 1/4 is 25. So I'm very comfortable taking 10 Exparel, 10 of 0.5, 10 of 0.25, putting it all together for a 30 ml block, ESP or something like that. Okay, so and by the way, they're using a solution called REC right now, ropivacaine. It's on Baccalaureate, yeah. Yeah, I just want to let you know though that what that is in case no one heard. So ropivacaine, epinephrine, clonidine, ketorolac, and honestly, I have noticed it's been working. And I was very skeptical, but it comes in this 50 ml bottle, and there's a lot of ropey in there. There's 150 milligrams in there. So when I'll add an adductor after they do their local infiltrative analgesia technique, so they're taking a syringe and they're injecting it subcutaneously in the arthrotomy, in the medial lateral gutters, the posterior capsule. That's called local infiltrative analgesia, and that's a good thing. But they realized it only lasts for about 6 hours. When it first came out, it was like, oh, you don't need to do blocks anymore, we're doing LIA. He said, well, it really only works for 6 hours. But this new solution has the clonidine, which is our dexmedetomidine type effect, and the epi and the toradol, which is working locally. It seems to be pretty functional. But when they use that, your adductor block, you really only need 10, 15 mLs, and I'll use quarter ropey. So I'm only adding a little bit more. I no longer will grab 0.5 ropey after they give all that direct solution in the field. And the same argument with the Exparel. I would grab some ropey quarter. Remember, ropey is 3 times safer than bupi. So they took lab animals, sadly. They infused bupivacaine in one, ropivacaine in the other. The dogs who got bupi, so sad they use dogs. The dogs that got bupi coated at 1/3 the dose of the ropey. And the dogs who coated couldn't be resuscitated with bupi, but they could be with ropey. So whenever you have a residency program and everyone's running around with needles blocking people on every floor, give them ropey, because bupi, you get an unintended intravascular injection, you could have last, which could be fatal. But in general, Zach, you take the Exparel dose, cut it in half, and that's how much bupi you can use. Yeah. All right, so just like a quick overview of the anatomy, we'll work through each of these muscles, but I want you to get the layout. So you got the pec major and the pec minor, and under that is the serratus anterior. So serratus anterior is on your first 8 ribs, and it attaches to the scapula, and it helps you push your arm out like this. You have these nerves coming out of the spinal cord as a nerve root. They give a ventral and dorsal root. The ventral root comes around the rib as the intercostal, and it shoots off a lateral branch that goes through these layers of muscle. So when we put local between, say, the serratus anterior and the lat, or between the pec minor and the serratus, or in the thoracoabdominal nerves, we put it between the internal oblique and the transverse, we're just taking advantage of those nerves in the plane that they're in. And that's why it's volume, because you want it to spread to multiple levels. And I'll go through the rest of the anatomy on each section. So to start, I don't know if you've heard over the years, all these new blocks come out, and then someone makes up a name, but they don't necessarily make the most sense, like QL 1, 2, 3, transmuscular, Pecs 1, Pecs 2. So not too long ago, there was this nice work done to kind of standardize the nomenclature. And pointer. So basically the rectus sheath block, the ilioinguinal iliohypogastric nerve block, we're going to go over. That's good for hernia surgeries. Doesn't get the genitofemoral, but it gets the skin and the deeper tissues. The tap block, more of a lateral or posterior tap. The subcostal TAP block for the upper abdominal incisions. And so just think about your cases and when you use each one as I go through it. So like a midline X-lap, phenicial, below the umbilicus incision. And then we have our Costal TAP we talk about. So we have the anterior QL, the lateral QL, posterior QL. I have great slides on that. One of the benefits of preparing is I got a better understanding of all this, so I'm excited to share that with you. And I tried to put the numbers, the labels by the numbers here. So, you know, you have this parasternal intercostal plane block. There's the superficial and deep. The superficial is the way to go because the deep you could touch the pleura and you probably will get the same effect. But again, you have the spinal nerve coming out and the ventral rami comes around as the intercostal. It gives a lateral branch, which gives an anterior and posterior cutaneous branch. That's when we do our serratus plane or our pecs or things like that. And then the nerve keeps coming around and then it comes to the front and it innervates the midline. So this would be for your sternotomy kind of thing. Now this is what used to be the Pecs 1 and 2 block. So now the Pecs 1 is called the interpectoral plane block. Interpectoral between the pec major and the pec minor. And the Pecs 2 is labeled by where you're putting the local, the pecto serratus. So between the pec minor and the serratus. But feel free to call it a Pecs 2 block. I bet most people you're communicating with won't understand the pecto serratus because it's kind of new nomenclature, but I just wanted to make you all familiar with it in case it sticks. And then we have the serratus plane blocks. And again, I'm going to have slides on all these. This is just a 25,000 foot view of everything. So we have the Erector Spinae plane block, which is where you put local on the transverse process, and the local can diffuse all over the place. It can go a little bit to the intercostal, maybe a little bit to the paravertebral space, maybe even back to the sympathetic chain. The retrolaminar block is if you move the probe medial from the transverse process, this lamina, if you put the needle on there, you'll get the dorsal rami very well. I don't see much use for this because you're going to get that with your Erector Spinae plane block too, but just so you're aware that that does exist. And then now we have the intertransverse process block, which is between, instead of being on the transverse process, it's between the two transverse processes above the paravertebral space. But what turns out there's slits in the ligament that allows it to spread paravertebrally. So I'll go over that with you guys. All right, so let's talk about Pecs 1 and Pecs 2. And again, I have a whole 1 hour lecture on this 2 blocks, so this is just going to be a broad overview. But basically, for the Pecs 1, so we have brachial plexus, and off the lateral cord comes the lateral pectoral nerve, and off the medial cord comes the medial pectoral nerve. And they run between the pec major and the pec minor. They're primarily motor nerves, but they do have afferents and they deal with proprioception. So when you're doing a large breast case, the thought is, by the guy who invented it, Rafael Blanco, that you're helping with that kind of postoperative pain, even though they're mostly motor nerves. And there is an artery in there, which the thoracoacromial artery is the pectoral branch. So you do look, anytime you're bringing your needle in, right? Just throw your color on for a second and see where the vessels are. Most of these nerves run with a vessel. We'll see that with the ilioinguinal and with the rectus sheath and all these different blocks. So look for a vessel. Your needle comes in, you put 10 mLs between the pec major and pec minor. I would not do this for a lumpectomy. I would do this more for deeper modified radicals and things like that. That's the Pecs 1, which is now known as the interpectoral. And if you advance your needle some further between the pec minor and the serratus, you're going to have this pectoserratus plane block. So remember, the nerve comes around, it gives a lateral branch, and you're transecting it with local to cover the anterior and posterior cutaneous branches. Since you're up more in the front, you're going to get more of the front versus a serratus plane, you're going to get more of the posterior. So if you're doing a VATS, you're not going to go with the Pecs block. You're going to go with the serratus plane block to get that posterior cutaneous branch better. All right, so this is what you see in real life. You put the probe on the front of the chest, and you push it all the way up till you hit the clavicle. And the first rib you'll see is the second rib. Then you count down 3, 4. Look, the pec, you can see where the pec muscle is. So you want to stay on there. If you come over here, obviously you're just over serratus. You want to be over the pec muscle. And you will see the pec major in the upper left here. the pec minor, and then you see this muscle here that goes above the rib body. That's the serratus anterior muscle, and your needle is going to open the plane between the pec major and the pec minor. You put 20 mLs there, and it will get a good T2 to T6 coverage, which is pretty much all of breast surgery. But it's the lateral 2/3. The medial third. Remember I showed you how the intercostal comes around and then it comes out the front? So you might miss this little strip. And I've done Pecs 1, Pecs 2, under just block with some propofol running for lumpectomies and things. And I did notice when they got medially, there'd be a little higher requirement for anesthesia because that area is not covered. But again, your needle's going to come into the pec major, through the pec minor, feel like a little fascial click. You give a CC, it starts to spread open in that biconcave kind of spread, and the space opens up very nicely. One more thing, like with the rib, the pleura, this is a pleura, right? So if you touch that, you have a pneumothorax. You cannot have a pneumothorax. It's unacceptable. It cannot happen. So you have to get through the skin, aim your probe back at your needle, find the needle tip in the first centimeter of tissue, and follow it to where your target is. If you go 2/3 and then find it, you could potentially have a pneumothorax. So we want to follow the needle tip, but the rib is a backstop in case you know, whatever, slip. So same thing with your supraclavicular, like get the rib in view so it's there, and so you don't touch pleura. I do know of a pneumothorax in this group in the past couple of years. It's just something that can't happen. It led to a chest tube, and it was an outpatient breast case. It just can't happen. Yes.
So when I teach you always have about these parts of the so I would just say the rib first, and then we talk a little bit so that, like we said, there's a safety margin policy, so that way that you know that you're not in aura and you are like for sure that you are on the table.
Yeah, it's a great point also because there are two approaches to that block where you are subfascial on the serratus, and the second is when you're in the plane between the pec minor and the serratus. I think they're both going to work. The muscle has blood supply, so the subfascial is going to get absorbed faster. Is kind of Lay's thinking, and in the plane between is sort of going to sit there until it diffuses out. And so, and when I go in between in the plane. I just want to point out this. I think this is a great representation or demonstration of the gadolinium spread in a patient when you do this block. And again, this is the gadolinium along the chest wall. And remember, the nerves come around and they pop out to the chest wall. So you can see how you're going to transect them with local and have an effective block. And the data is pretty clear. If you do this, their pain scores and morphine consumption are improved. All right, so that's the approach for breast surgery. Now, the serratus anterior plane block is also going to cover the breast, the same nerve. So you can do this block for your breast cases as well. You can do this for rib fractures in this region. You can do this for your thoracoscopy cases or your thoracotomy cases. And basically, you're hitting the same nerves. We're just going to, and there's two positions. If you're already on your side on a beanbag for your VATS, just do it right at the end. It's right there, low-hanging fruit. But it's nice to have a supine option for any block for rib fracture patients because they don't want to move. All right, so again, the nerve comes around and it comes out to the chest wall. And when we put the local, this is showing this serratus plane block, two approaches. One is the superficial and one is the deep. Just like I was talking about a second ago with the Pecs block, the deep is either way you're going to transect the nerves. So the lat muscle, everyone knows that muscle. That's a big one that you can find. You see it on everybody. And in between the lat and the serratus is like dorsal artery and the long thoracic nerve. And so you could look for an artery to help you find that plane. Although I find it very easy to see this plane. So you're just opening up with probably 40 mLs of quarter to get pretty good coverage, and you will get this dermatomal coverage. You know, see what I'm saying? Again, here's a look at the nerves and how you're covering the anterior and the posterior cutaneous branches. So this is the lat muscle, and this is the serratus muscle, and you're putting the local between the two. And this is a gadolinium study showing the spread with the serratus plane block. All right, moving down. Again, you want to be thinking about what cases you'll use what for. What's not shown on here is the external oblique intercostal block, which I think is going to be great for us for our hepatobiliary cases, liver cases, where in the past it was hard to get a subcostal TAP block because the incision, you know, you do a pre-op and the surgery lasts 6 hours and the block was only going to last 12 hours. It's like, it's better to do it at the end. But at the end, there's a big bandage there. So I'm going to show you the external oblique intercostal block, which when I was researching this, I was looking up articles, and our Dr. Kalika wrote one of them, so I thought that was pretty cool. But anyway, we'll get to that in a minute. The middle circle here is the rectus sheath block. So I think it should be part of our pathway, especially at night. You have an open midline, because that's when we see most of our midline incisions at night, right? Because they're usually X-laps for that laparoscopy is not an option. If you got a midline X-lap, it's such low-hanging fruit to do rectus sheath block. It is just a very painful surgery that, you know, you don't want to go to McDonald's and get like a burger that looks different depending on what town you're in. You want each patient to get the same experience. So we really want to offer a pathway, you know, that each patient gets this or that, you know, for example, pre-op Celebrex, Tylenol. We don't want it to be like one total knee gets it and the next one doesn't. That's not really fair to the patient who does it, assuming it works well. So the rectus sheath block I'm going to discuss for midline X-laps. It's not the best down here below the belly button, and I'll explain why. But for the midline X-laps, rectus sheath. And then we have our subcostal TAPs for you know, T6 to 9 kind of thing. The QL is supposed to be like T6 to L1 kind of thing, or maybe not quite up to T6, but the whole thing. And then what they're finding is like the posterior QL, the TAP, you know, the lateral TAP, they're really for the belly button down. So it's great for a C-section. So you crash the section. They don't have astromorph in their spinal because you crash them. They deserve a standard old-fashioned lateral TAP or posterior TAP or QL, because that's a lot of somatic discomfort, which also brings like somatic versus visceral. So somatic is the incision. Visceral is, you know, when you do a hysterectomy and you cut above the cervix, that's the visceral part, and that's crampy and that's painful. These are all somatic blocks except the QL. The QL, because you're so close to the paravertebral space, you're getting that whole ventral rami that's going to get the somatic and the visceral potentially. But keep in mind that you may not have a 0 pain score, but you may have a 3-point pain reduction, which is relevant, right? Like Celebrex lowers your pain score by 1.5, Tylenol similar, pain block 3 points. It adds up, and hopefully we can get them what would have been a 7 in the 3 range, which is totally manageable. And I tell them, like, pain has a purpose. If you had your hernia and didn't hurt, you go right back to swinging a golf club, it would tear wide open. So pain limits you to only do what your body knows is capable of based on the tissue healing. So I think that helps them understand it a little bit, but I'll say it gets out of hand and we want to minimize it. All right, so this is the EOI, external oblique intercostal block, and this is the dermatomal coverage that you will have. So as you can imagine, and if you do bilateral, it gets to midline, you'll get this whole, you know, chevron kind of potential. But if your gallbladder turns open, or if you're doing a liver case, that's where this can shine. And there's a modified EOI where you can get like a flank a little better for nephrectomy. So the external oblique muscle and the rectus abdominal muscle insert onto the ribs. 6 to 9 for the external oblique and 5 to 9 for the rectus. So basically, remember I was saying the breast is 2 to 6. So this is 6, right? Nipples like T6. So you put the probe on there and you see a rib. You cannot miss it. On top of the rib is the external oblique muscle. So this is the ultrasound image, and you're just lifting the external oblique off the rib. That's it. The black mark here is the probe position on the opposite side. They just couldn't overlay the two images, but they're demonstrating where you put the probe for this block and the kind of coverage you will get. Again, use the rib as a backstop. 20 to 30 ml is a quarter, or you can leave a catheter. This is a video, but I saved it as PDF, so I don't think it's going to work. And then the modified approach is basically just a little more lateral. And that's kind of, they're exploring that technique right now. So see with the probe position here, instead of it being here, you're over here above where you do your flank incision. All right, so there's 4 kinds of taps. We have the subcostal TAP. Probe is here. You see the rectus abdominis muscle. I'm going to show you a slide on that. We have the lateral TAP. The anterior TAP is also known as the ilioinguinal iliohypogastric block, and the posterior TAP, which is getting to the QL region there. We'll talk about. All right, so I want you to look at that image there. This is the psoas muscle right here, and this is the quadratus lumborum muscle, and these thoracoabdominal nerves are coming out between there. So the nerve emerges from the border of the psoas, and it runs over the anterior side of the quadratus lumborum muscle, deep aspect of the transverse abdominis. It then pierces the transverse abdominis and enters the TAP plane. So when you block it down here, it's in the TAP plane, the plane between the transverse abdominis and the internal oblique. Versus when it's retroperitoneally, it's not in that plane. So it comes out between the psoas and the QL, comes around, pierces the transverse abdominis, and now it's in the plane where we do our regular TAP blocks, and that's why it's considered a TAP block. I take the probe and I see my ASIS. The probe is aiming from the ASIS to the umbilicus. So it's like this. When I go lateral, I see the bone. You can't miss bone. It's cortical brightness with dropout underneath, and it shoots down. We've all seen like Pang blocks where you have your inferior iliac spine, your IPE. If you follow that laterally, you see your ASIS. So you have your ASIS, and then external oblique, internal oblique, transverse abdominis, and in the middle is 3 things: an artery, the ilioinguinal, and the iliohypogastric. This one I kind of try to do before surgery because a lot of times the bandage is in the way. But this would be for an open inguinal hernia. It's going to cover the 2 nerves that are here. There is this deep circumflex iliac artery, and I point this out because one time I was doing this block, like normally do, because the guy I worked with did a lot of open hernias. We don't see open inguinal hernias as much anymore because they're doing them with a robot. But I put the stimuplex, the needle in, and I always aspirate, and like bright red blood came back. And I was looking, I'm good at it. I didn't think, and I was in the artery. So I want to point out that these 2 nerves run with this deep circumflex iliac artery, and I do localize it, just like I do with Pecs 1 block. I do localize it before I bring the needle in. So my needle will just drop down and open up this plane. All right, easy breezy. So spend some time on the rectus sheath block. So we have the ventral nerve root coming around. They become what they call thoracoabdominal nerves. through the plane between the transverse abdominis and internal oblique. And then when they get to the midline, they go through the rectus muscle and they cover the midline like this. So these are two nerves, left and right, coming through the muscle, and they pierce what they call the posterior rectus sheath. So this is the arcuate line. Arcuate line, above that, there's a posterior rectus sheath. Below that, there's only the transversalis fascia. You want to be above the arcuate line. So this block is done above the belly button, at or above. And pretty much everybody, you see bodybuilders, they all have that six-pack, but everybody's got this rectus muscle in there. It's very easy to see. When I can't find it, I start lateral, push hard, I see the tap view. I follow it medial to the linea alba, and I see the rectus muscle. And basically, the needle should come, and I've taught this wrong to some of you, so I want to point out, because I just saw some new work. I did like a recent lecture of just a rectus sheath, and the spread is better if you come lateral to medial. So I'll have you stand on one side and do that and reach across, but I want you guys to come lateral to medial with your needle angle. So probes here, needles coming lateral to medial. And here's a nice view of the nerve coming around and coming through the muscle. So if we put local here, we're going to cover the midline. Now, you don't want your needle to go into the peritoneum. I haven't found any cases of bowel injury. The bowel's floating, and this is a blunt needle. Why do we use stimuplex needles instead of 25 gauge needles? Because the angle bevel. So our stimuplex needles have like a 50-degree bevel. A 25 gauge needle is like 9 degrees. So you can get right into the bowel with 25 gauge needle, where this would kind of like hit it and kind of push it away. That's the idea why you don't get intrafascicular with stimuplex needles. But if you did like a dart, you obviously could get in there. But in general, if you end up in the peritoneum, I don't think you have to lose too much sleep, but you don't need to. The best way is to give a little puff of saline on your way in, so you can see your needle tip if you can't find it. If you can't find it, you just pull out, start over. So basically, you need to see your target, your needle, and the spread to be safe. If you lose any one of those three for the rest of your career during a block, just stop, pull it out, get your view again, and go back in. Because I've seen people get very blinded by ultrasound. They're so focused on the screen, you don't realize that they lost their target, the needle. And if you don't have the spread, it means you could be in a vein or in the pleura or intrathecally. So you want to see spread on the field. As long as I'm seeing spread on the field, I'm not in one of those three bad places. Just want to point out that the neurovascular bundle is with the inferior epigastric artery. So we want to look for that color flow. This is the rectus muscle, posterior rectus sheath, transversalis fascia. Arcuate line, you see this kind of like, you can see the back of the abdominal wall, the rectus from behind here. Above that, this will act like a fascial sheath for you to fill with local. So when you do these blocks, you'll see that spread goes north and south. This was with a lateral needle approach, you can see the nerve is covered better than the medial needle approach. The nerve didn't get covered with the dye. So that is where that came from. As far as complications, I was surprised because Jared told me that he had saw a hematoma at his training center, and I was like, well, I never want that. And then this small case series, let's see. So the N was 4,000. So not that small, but 8 times you don't want it. You just don't want it. So how can we avoid the vascular injury? This is the vascular supply. The inferior epigastric artery is really big below the arcuate line and lateral. So above the arcuate line, we still have it to contend with. And it's not always this vibrant, I will tell you. But I want you guys to put the color flow on and look at that posterior border of the rectus muscle and stay away from it. So your needle path, you would want away from there. Nice that it's on the back wall, you don't have to worry. You know, like for example, in the middle scalene muscle, when you're doing interscalene, the long thoracic and the dorsoscapular in the muscle body, and this is on the posterior wall, so it should be fairly easy to avoid. If you start here and open this space up, the local will spread this way. So the subcostal is for T6 to T9. And basically what you're looking for is the space between the rectus muscle and external oblique. So here's a drawing from the NY store. So when you're looking for block videos, oh, you guys are so lucky to have these two. Like, this just didn't exist when I was training. So Duke has incredible series. The guy Jeff Gatson there, he trained here at St. Luke's. He was Noreen Sakowitz's co-resident with Admir Hadzik. So Admir Hadzik is NY Sora. So this is what NY Sora pictures look like. They have their own graphic artists and stuff that do these pictures and animations. Great. So NY Sora is Admir Hadzik. He moved to like Netherlands or something like that, but he still puts out incredible stuff. So the NY Sora videos are incredible. And the Duke videos, Jeff Gatson trained under him, went to Duke, and his videos are outrageous. So I would, when I search for a video, I type either NY Sora or Duke. I usually type Duke Gatson and then the name of the video, the type of video, and it comes up. But again, you have your rectus muscle. We just talked about how to see the rectus. But this is subcostally, so the planes look a little different. You still have the three planes, the transverse abdominis muscle, the internal oblique, and the external oblique. But once you get up in this upper abdominal portion, the TAP muscle is underneath the rectus muscle. So you're opening this plane for T6 to T9. I'm going to reach more for the external oblique intercostal now instead of this, but just so you're aware, this is one of the four: anterior, inguinal, iliohypogastric, lateral and posterior for the fenestrial stuff, and subcostal. Those are your four types. The standard TAP, which would be like your 2AM crest C-section, starting the belly button. You want to get lateral as far as you can. You have the iliac crest here and the ribs here. You're in the middle. You're pushing hard. You're looking for little hyperechoic structures in the posterior part of that plane that are the nerves, and you're opening that space up. So as your needle comes in, you'll feel a click, and you'll open that space with, you know, whatever, 15, 20 mLs each side. All right, so the internal oblique is always the biggest muscle. So when you're looking at layers and you're like a little bit confused, you say which one's the biggest. That's the internal oblique. Because sometimes it's hard to tell if this Camper's fascia up here is a muscle layer or not. So I'd look for 3, with the internal being the biggest. All right, now the posterior TAP starts to get into the lateral QL. Like, it's a little bit of play on words now, whether the posterior TAP is the lateral QL. But the idea here is that so the TAP is here, the lateral TAP is here. This is a little more posterior. And I should put some work there that shows that it's a little more effective than a lateral TAP. All right. I found this a very difficult topic over the years. So I don't expect the people that are not familiar with it to walk away from here familiar with it. It's an overview, and you can refer back to it and watch some more videos. But basically, I typed in the new names right here. So these are the new names. The old names were 1, 2, 3, or 1, 2, and transmuscular, actually. But the new names make a lot of sense. So what are we looking at here? The external oblique, internal oblique, transverse abdominis. Those muscles come back. This is the lat muscle right here. This is the QL muscle. The QL muscle sits on the iliac crest, attaches to the rib and to the vertebral bodies. And this is why I want to show this slide. This is the nerve we're going after. So you want to ask yourself, how do I get the nerve in each block? So you can see how you get it in a TAP. You always do the block more proximally when you can, though, right? If this is like the femoral nerve, I don't want to block it here where it's a bunch of anterior posterior divisions. I want to block it where it's my wrist and it's all together. So again, anything more proximal is going to get more of that whole ventral root, which is going to be somatic and visceral. So if we block a TAP here versus a posterior TAP here versus a lateral QL here, the posterior QL, I don't think if they really know why it works so well, but it spreads, I guess, in both directions, and it gets there eventually. And this is the anterior QL, which seems to be the one you want to do. Now, the lateral QL is going to be easier because you can be supine and just bump the hip. The anterior QL, you got to be pretty much lateral, and that's a challenge. You know, it's a challenge at the end of the case to turn someone on their right side, turn someone on their left side. But I don't know, if you did a nephrectomy and you're in the PACU and the guy's hurting and you put him on his side and you do it in anterior QL, that might be a home run. So we'll talk more about that, but I got a bunch of slides here on it. Basically, I wanted to show you the psoas muscle, the QL muscle, the nerves coming out. This is the Erector Spinae group of muscles. This is the QL muscle, and this is the psoas muscle. The psoas muscle is the filet mignon at a restaurant. It's a hip flexor. It attaches up here, inserts on the lesser choke, and it pulls the femur up. So that's what the psoas is. It's a very vascular muscle. And the lumbar plexus is over here. So if you go too far with an anterior QL, you can get a lumbar plexus block and have a weak leg. But pretty much we have the lateral QL, the anterior, what used to be called the transmuscular QL, and the posterior QL. This is the one that I think is probably most effective, the anterior QL. I like these dye studies. This is what a TAP spread looks like, and this is what a QL spread looks like. And this is from behind, QL versus TAP. Pretty much more proximal and wider. So again, we have the spinal cord with the psoas muscle, the QL muscle, and the rectus spinae. This is called the shamrock sign. So the transverse, I'm showing it in the opposite direction as if it's this side of the body. But if you flip this up, when I flipped it, the letters were backwards or whatever. So pretty much the QL muscle is one of the three leaves of the shamrock. The rectus spinae muscle is another leaf, and the psoas muscle. And the transverse process is the pedicle of the shamrock. All right, it's lecture. It's got to be a deep dive. I'm sorry, but we have the PRS fascia in here, and then the TLF fascia. There's anterior, middle, and posterior. The thoracolumbar fascia. They basically wrap the muscles. So again, lateral TAP, and lateral QL, anterior QL, posterior QL. So your anterior QL, the needle's between the QL and the psoas muscle. So why QL versus TAP? When you do a QL, your blood level of local barely spikes because it's kind of sitting. It's not getting absorbed as much. You're getting a wider coverage with the anterior. It looks like with the posterior QL, you're only getting umbilicus down. And with the lateral, same thing. So anterior QL is really the one that gets you this wide stripe. And you get 24 hours of analgesia. I think a TAP only lasts 8 to 11 hours, maybe even 6 sometimes. So if your QL is going to give you 24, that's a good thing. So you might want to start, you got a super lean X-lap in the middle, like say a trauma. Gunshot, they got a big midline X-lap. They're like 100 pounds. Perfect opportunity. Put them on their side. It's the middle of the night. There's nobody jumping down your throat to get the next case in the room. You can offer this patient a very good thing. He's 100 pounds. You put him on his side. You take the curvilinear probe, and that's where you get good at your anterior QL. And that is T6 to L1, somatic and visceral, 24 hours of coverage. You got a rotund robotic case with 4 cases to follow. That's not where you're messing around getting comfortable with this procedure. All right, I'm gonna go through each one. So this is, you bring your needle from the midline to lateral because the kidney is in the other direction. The kidney is there, you know, so the kidney you can get over there. So you start from the midline and you move lateral. Curvilinear probe. This was just one study that showed that the anterior seems to be the best QL. This is the shamrock sign we talked about. And this is what we'll see on the screen. So the psoas muscle has this look. It's different kind of look. It's very marbled, like a ribeye kind of thing. That's why it has that look. The QL is super lean. So we have the transverse process here. That's bone. We have the rectus spinae group here, the QL muscle here, and the psoas muscle here. All right, so kidney and the PRS fascia versus the psoas with the anterior TLF fascia and the needle through the rectus spinae muscle through the QL muscle between the QL and psoas to get somatic and visceral coverage. I think we have more than an hour. I got a lot to do. All right, so lateral is basically your tap is here, your regular tap, and then your posterior tap or lateral QL is getting a little more in this, what they call the lift fascia. The lift is like the lateral portion of the QL area. And then this QL2, I'm not sure if anyone's really doing it, but it's more superficial, and but it's only going to give you really belly button down, so I'm not going to go there. All right, Erector Spinae blocks. This is you'll do on call. We do rib fractures. So you have a rib fracture. It's kind of posterior lateral. You go for Erector Spinae. Maybe it's a little more anterior. You might do serratus anterior. If you're with an attending that likes doing it, paravertebral is going to be better, or the intertransverse process block. So this is where I'm going to go now. The Erector Spinae group. So basically, this is the transverse process. The paravertebral block is closer to the pleura. If you put the needle on the bone, you can't have a pneumothorax, and that's why everyone likes it. It's 30 mLs a local, and you'll definitely get the dorsal rami, but you hope that it spreads and gets the ventral rami. Not to beat a dead horse, but the nerve comes around, dorsal rami, ventral rami, gives off a lateral branch, anterior, posterior, cutaneous branches, comes along the chest, comes out the front, and that's where the midline is covered. So we're trying to get it spread to these areas. Here's some data that it provides effective analgesia. Okay, what I've read is that an ESP lowers pain after a rib fracture by 3 points for up to 24 hours. So if someone's on the phone with you, like, you need to do this block, it's like, you don't need to. It helps a little bit. It's not a game changer. You know, where really you want to get up there is when they're having trouble breathing. You can make a difference to prevent them from getting intubated. But whether or not I can wait till morning, like, the block's going to last this long. So if you do it in the morning, it's going to get them closer to discharge versus the middle of the night. So in other words, you could do other modalities, parenteral opioids, Celebrex, Tylenol, icy hot, and you can have the pain team do it during the day. It is good to get stuff done at night, though, because the day might be busy, and then the patient gets kicked off till like late in the day, in a lot of pain. So go see the patient, determine if it's urgent or not, are they struggling, and then make a decision. You know, we can offer this for you tomorrow. It'll lower the pain about 3 points. Now, sometimes I'll see patients do a lot better than 3 points, and sometimes I'll see patients get no relief. And that's why the ESP is not great. It's variable. But there's data for it. So let's go over the anatomy of it. So starting from the outside, you have the trap, the rhomboids, and the lats. So we're going through that. Deeper than that, you have this erector spinae group of muscles, which is the longissimus, the iliacostalis, and the spinalis. That is your erector spinae muscles. They keep you erect, your back erect, so you aren't like a bunch of jelly. So that's erector spinae group. And then below that is like the spinalis muscles, the multifidi muscles, all the muscles that kind of help keep your spinal cord safe. All right, so we put the probe on the midline, and you see a spinous process. That's super easy to find because it's a bone very close to the skin. Once you have the spinous process, you move laterally and you see the lamina. And then it becomes a tombstone. That's the transverse process. Then you go more medially and you see a curved rib. So I do this from the beginning. I go midline to lateral, lateral to midline, and it helps me define it. When I'm lateral, I'll see a rib with pleura moving. That is not your erector spinae block. You don't want to see any pleura when you're over the transverse process. So if you see pleura moving, you're still over the rib. As you come medial, that rib will be curved and it'll become flat. That is the transverse process. Then I'll go a little more medial, see lamina, spinous process, and come back to where I had that broad-based transverse process. Then you can come in plane or out of plane, touch the bone, and lift the erector spinae group of muscles off of the transverse process. And it says like 15 to 30 mLs. I do 30 because I feel like I want it to spread everywhere. And this is one time where you want to push a little hard to get it to lift up and to spread. If you push it slowly and easily, it'll just kind of follow like a stream will always go down the stream pathway versus a flood will like go over the banks. You want to kind of to go everywhere. So you get the intercostal, the dorsal rami, it'll get taken back into that chain. And then through the slits in the superior costal transverse ligament to get to the paravertebral space, which is where you get the most effect. They say you get 4 levels in each direction. So if you have to look at the CAT scan and say, where are the broken ribs? It's like, okay, 2 to 7. I'm going to go in the middle of that. Or, which ones are the big pain generators? So if they have a 2 and a 3 rib and then a 7, 8, 9, I'm going to go up to the 7, 8, 9 because they're more associated with respiratory motion versus these guys are just hanging out up here. And so sometimes you have to make a decision. I'm going to go after this one, even though you have other fractures. All right, just some images. Your needle comes in. This is the erector spinae muscle. You touch the transverse process, put 20, 30 mLs. As you make a space, you can put the needle into the space and kind of hydrodissect as you go. I don't know, like when you're doing like surgery, you want to say, where's the blood supply to that surgery? And that's going to follow the neuro innervation. So for example, the celiac axis is T5 to 9. So anything liver, spleen, stomach, pank, I'm going to go in the middle of that versus the kidney is like 8 to 10, so that's kind of how you pick your location. Right, so you have the transverse process, right? One vertebrae, the next vertebrae. In between there is the intertransverse process space. So this is something new. And I would say the evidence is coming out now. But if I'm there already, I can just put the needle a little further and go to this space. So let's look at this, right? This is your transverse process. And this is your rib below. That's connected by the superior costo-transverse ligament. This is the paravertebral space right here. So in here is your ventral nerve root. So it's your densest cover. If you want to do a breast case with the patient talking to you, you're going to do a paravertebral block at T2, 3, 4, 5, 6. Versus if you want for post-op pain, you do a paravertebral block maybe at 3 and 6 or 3 and 5. Or maybe just the whole volume. Like you do like 20 mLs total for paravertebral. You could do 5, 5, 5, 5, or you could do like 10, 10. But it's I know I'm throwing a lot of names at you, but they're all named by where they're attached. So transverse process. We just talked about how to find the transverse process. So you have that already. And we talked about how to find the rib more laterally. Where the transverse process, obviously the ribs attached to the midline at the transverse process. So you're going to have a rib and a transverse process together. And you're going to see that when you're doing your scan around the erector spinae. But the rib below that level is connected to the rib above that level with the superior costo-transverse ligament. And if you pop through it, you're in the paravertebral space. The good news is the dorsal rami comes out through the superior costo-transverse ligament, and that's a hole in the superior costo-transverse ligament. So if you put your local in this intertransverse process space in this complex here, local will get to the paravertebral space, and you'll probably have a more effective block than your ESB. So paravertebral leg spread without entering the paravertebral space. Cadaveric MRI studies show spread to the paravertebral and intercostal spaces. Comparable pain relief and opioid reduction to paravertebral. Correct. So that's the Pecs 1, Pecs 2, serratus plane, the external oblique intercostal, the 4 taps, the 3 QLs, the ESB, the ITP, and last but not least, the paravertebral. So you guys are lucky. We have multiple fellowship trained regional anesthesiologists working here who can do this with you. So you want to find the right opportunity to do your first one. And that right opportunity is a skinny rib fracture at night. Because you can take your time, you can see things. The paravertebral is not great in a big guy. You know, sometimes you need a curvilinear approach just to see the transverse process. I'm not going to be fishing around by the pleura in that person. Unless you maybe have a chest tube on that side already, then you get a little free pass. But you don't want to violate the pleura. So the spinal cord gives out a nerve root, a ventral and a dorsal rami. Dorsal rami goes and feeds the erector spinae group, the paraspinal muscles, the multifidi, the sensory, very proximal. May have some good effect for spine surgery because they cut through those tissues. So yeah, the dorsal rami retrolaminar block may be good in spine surgery because you get that axial component. But we are going to block with the paravertebral block between the pleura and the superior costal transverse ligament and the vertebrae. Those are your borders of paravertebral space. Transverse process to rib. Superior costo-transverse ligament. It's just the back, you know, like adductor canal has like the adductor magnus, the sartorius, and the vas medialis. Well, these are the borders for paravertebral. This is the ligament. This is the ligament. I wanted to show you the probe position. So you start midline, you move laterally, you see your transverse processes, and then you get a little parasagittal and you wag. And you see best when you're 90 degrees to the target, and so you have to eat toward the target. So needle. This is out of plane technique. You can do either, but very steep angle, you're gonna see your needle anyway. Might as well go out of plane and just give a little half cc of saline. Put a stopcock on. One saline and one's your block stuff. You're not wasting your block stuff. So you just give a little cc and you see spread here. And you give another little cc and you see spread here. That's an ITP block. And then you go with another cc and you see spread here and the pleura moves down. That's your paravertebral. So out of plane, hydrodissecting, or not so much hydrodissecting, but hydrolocating, and 5 to 20 mLs, maybe 5 per level, and 0.5, 0.5, whatever. Remember, anytime we're doing these blocks, you could have epidural spread and you get hypotensive. You could screw up somehow, get in the dural cuff, you know, if the nerve becomes dura at some point, give intrathecal, have a total spinal. So you never just like do a block and bail or not be ready to intervene. Like we can fix all that stuff if we were prepared. One time I was not prepared. I was on the floor. I was doing the ESP. The guy's jaw was marred shut from his trauma. And I did the ESP and he was like, again, dizzy, lightheaded. And my whole career flashed in front of me because I was like, I'm not supposed to be even doing this because I was on the floor. At the time we didn't have the okay to do blocks on the floor, and his jaw was wired shut, so I wouldn't be able to intubate him in a heartbeat. And I didn't have any emergency drugs. He just got lightheaded because he was vageling from me sticking a needle in his back, and he was fine. But it made me realize, like, it's better to do this in procedural areas when possible. Better have. I always bring a neoephedrine in my pocket when I do these blocks, and I don't bail as soon as I'm done because they're not in a PACU. Someone's watching every blood pressure every 5 minutes. On the floor, no one's around. So if you get some epidural spread in you, that might be fine. But if you've got critical AS, you could code. So you basically have to keep the same standards that we keep downstairs when you're up there, which is good because you could just write your note while you're there, and by the time you're done, you should be in the safe period. All right, it's this picture again. Paravertebral. All right, I think we've covered a lot. Yes, sir.
So when I was in developing, actually, and go on with paravertebral and then not go on. The needle actually got really steep, and there was a lot of times that the portion of the material was on the eye was not see that. So I was relying on a lot of push down. Like, no matter how, much the control or energy, always be perfect. But that's nosy kids. I don't know, like, that's the thing. Oh, I don't know.
Yeah. I think what's cool is you can adapt at that moment and say, I'm going to do ITP. I can't get a good view. For me, pneumothorax is a never event. You know what a never event is? It's not like, oh, that happened, that's a complication. No, it can't happen. So if I don't have a good view, I'll just do the ITP. And there's some data that it's equivalent to paravertebral. There's some data that Pecs 1 and 2 is equivalent to paravertebral for post-op pain. But sometimes you need paravertebral. And then you also have the epidural option. So if I have rib fractures here, 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 and here, maybe that patient's right for a thoracic epidural. Like maybe that situation is good for a thoracic epidural. It's a lot more following the patient and all this stuff. They can't be on like a lot of Lovenox and stuff, but maybe that situation is the right time. So